Today we approach a neonate. We are called to the obstetrics and gynecology ward and we learn how to examine this neonate. So we put from top to bottom, we put our finger on the fontanelle to see whether there is a chance of hydrocephalus. We look at the eyes, bulbar conjunctiva for jaundice or blue sclera, which indicates unilaterally a buophthalmos, and if bilateral it indicates osteogenesis imperfecta. Osteogenesis imperfecta in short is multiple maluniting fractures. Then you go to the cleft lip and palate, then sternomastoid contracture leading to torticollis. Then if the child gets cyanosed after feeds, you consider a tracheoesophageal fistula. If the child is cyanotic and you hear murmurs around the heart, it is congenital heart disease. If the child vomits after feeds, consider achalasia cardia. If the child cries after feeds, there is a lump in the hypochondrium and you find that there is a visible peristalsis from left to right and you are feeling a pylorus, you can palpate it, then it is pyloric stenosis. All this is upper GI obstruction. Then you look, if there is jaundice, it can be icterus neonatorum, but there can be congenital hemolytic jaundice, and Krigler-Najjar syndrome is an example of it. Then you look at the hypogastrium and look for ectopia vesicae and hypospadias, an imperforate anus, and congenital megacolon or Hirschsprung disease. Then you go to the back, see the neckline and whether the scapula has descended properly, that is Klippel-Feil syndrome and Sprengel shoulder. Then you look at the spina bifida or spinal dysraphism, in which the spine has not united and the meninges can bulge out of it. So there is meningocele and meningomyelocele. Then you look at the upper limb, you see fused fingers, you see congenital absence of limbs, and you can see multiple or more than the normal number of fingers. Then you go to the hip, and if you abduct and externally rotate the hip and there is resistance, that means the child is not able to reach a cross-legged position, then you think of congenital dislocation of hip. Then if the knee is not bending, consider that the muscles have been replaced by fibrous tissue. Myodysplasia, muscle wrong development, fetalis in the fetus. So muscle converts to fibrous tissue. Condition is also called as arthrogryposis multiplex congenita. Then you look at the club foot, you look at a vertical talus which can cause congenital pes flavis. So this completes your checklist. If I have forgotten something, you can add to it. But here we will mainly now cover congenital dislocation of hip. So you see that cross-legged sitting is resisted. The child is unable to abduct and externally rotate the limb. If you make these knees meet in front, you find that the thigh is shorter. You do a telescopy, that is positive, and you feel the femoral artery on the side of the dislocation The pulse volume is less, which means the vascular sign of Narath is positive, and this makes it a clinical diagnosis of congenital dislocation of hip in a neonate. In a adult, the picture will become a little different. You order an X-ray of the pelvis, both hips. You draw these two lines, a vertical line from the tip of from the superior margin of the acetabulum, which is called as the Perkins line, and a line joining the two radiate cartilages, which is the Hill-Jenner's line. You will find that there is a small epiphysis. Epiphysis is small. The head is in the upper and outer quadrant of the Hill-Jenner-Perkin line crossing, and the Shenton's line is broken because the femur has gone up. Then you can see that the acetabulum is shallow. That means the acetabular angle between the acetabular line and the Hill-Jenner's line is obtuse, is more than 50-60, when normally it should be 25. So this is what you see on X-rays, and after a radiological diagnosis, you think of the management of this case or the treatment. So you reduce by abducting and externally rotating so that you can reach complete cross-legged sitting, and you may have to push the head into the acetabulum. This is called as the ortolani maneuver. The reverse of it, where you can dislocate the head, is called as bar low. Bar low means bahar low. If the child is older and you fail to close reduce, you will retain the close reduction by what is called as a von Rosen splint. If you fail to open reduce, then you have to deal with a shortened pelvic-femoral muscles which are preventing the descent of the head to the level of the acetabulum, and this you deal with by a subtrochanteric femoral shortening osteotomy. Then you may have to deal with this iliopsoas causing a contracture of the capsule by releasing the iliopsoas muscle. Then you may have to deal with the inverted labrum, which is preventing the reduction of the dislocation by removing the labrum out of way, and you have to deal with the filled acetabulum by removing the filling. After this, you may be able to reduce and retain by a K-wire across the neck into the acetabulum, but this may not be stable because the acetabular angle is obtuse, is 50-60, it should be 25. So you have to do a supraacetabular osteotomy, pelvic osteotomy, and you have to restore the acetabular angle. Good containment by von Rosen splint will prevent your doing all this. So pelvic osteotomy, supraacetabular, to restore the acetabular angle, is of 4 types: Salters, Dial, Pemberton and Chiari. Those who want a distinction should know about them. Now, an old case, neglected case. So he will walk with ipsilateral lateral bending of trunk in the mid stance to keep the line of weight bearing in the foot. So this I need to explain a little. If this is the pelvis, This acetabulum has been raised because this ankle has gone into plantar flexion because of the gastrocnemius. This is the limb which is weight bearing, and to keep the weight in the area of the weight bearing, the spine is tilted and the line of gravity is now passing within the weight bearing area of foot. This is possible because the gastrocnemius has lifted the opposite side acetabulum up in the toe break phase, and the gluteus medius of this side, acting from its insertion, is maintaining this iliac crest lower. Now supposing the gastrocnemius fails, that is the power fails, the lever arm fails, the neck fails, or the hip fails, that is the fulcrum fails, then this mechanism will not work, and this side of pelvis will start going down. To maintain it, the spine must tilt in the same direction so that the line of gravity keeps on passing within the area of foot. So ipsilateral lateral bending of trunk in the mid stance phase to keep the line of weight bearing within the foot area is called as Trendelenburg gait. Bilateral Trendelenburg gait is called as waddling gait. So in this case you don't prefer a reduction because it is a very major operation. There may be too much of shortening and you may still be unable to reduce. So you do a osteotomy at the level of the ischial tuberosity. This osteotomy is a valgus osteotomy. The lower end is parallel to the trunk, the upper end is parallel to the false pelvis, and the angle of osteotomy is equal to the pelvic angle. So this pelvic support osteotomy is a treatment of unreduced congenital dislocation of hip. See, this is the femur which has now taken the shape of the pelvis. So it will prevent abduction or adduction, and it will prevent upward migration of the femur. So this ends our class on congenital dislocation of hip.